surgery. You can see she still has an IV on her hand, and this is immediately 24 hours post-op, and that is the kind of result you should expect. So here the patient had not lifted her arm at least for the past 3 months. So she had a little weakness in the deltoid, but we tried to overcome that in the next few months. I'll present a second case, which is a little bit different than the first. How? The patient is not diabetic in this. So there is a 66-year-old male, no history of trauma, no history of diabetes, but with a similar range of movement. Forward flexion was just 90 degrees. Internal rotation was classically only up to the waist, and external rotation was only 10 degrees. Now the patient was, advised physiotherapy. He was already doing physiotherapy. He was not getting any result. He was getting stiffer day by day. Actually, the reason for the patient to get stiff was physiotherapy, because the patient had a pathology inside the shoulder. The patient had a subacromial spur. The patient had a problem in his biceps, but he was not treated for it, and he was just blindly advised physiotherapy. And that is where he was, deteriorating instead of improving. So the patient, by the time he presented to me, was so stiff that I really couldn't advise him any other treatment. So by the time he came to me, his long head of biceps was already, burnt out. His cuff insertion had not become painful at all. So, it was a mixed picture that the patient has no painful biceps, the cuff is all right, still not diabetic, what else to do? So then we did an MRI, we found out that the patient has a spur, the patient was not improving with physio, his biceps was tender, the patient had classical night pain. And then we decided we'll undergo a procedure. So this was the patient before surgery. So here, if you see, it is 90 to 95 on the forward flexion. The internal rotation was classically only up to the waist. This is the worst it can get. This is 0 degrees. Intraoperative, if you see, this is the classical image of a subacromial spur. So this is basically the extension of the acromion, which is sort of impinging on the underlying muscle. So the space between the bone and the muscle has reduced to only say about 4 to 5 millimeters. So this reduction in space is the reason for constant hitting of the muscle to the bone, and that has led to a painful shoulder. So what we do is we try to use a burr and smoothen the bone out. Now if you see, once the bone has been completely smoothened, the spur which is there on the left hand side is completely gone on the right hand side, and that has led to complete opening of the space. And this is one of the things we do along with the capsular release. So the same patient, the capsular release also has been performed, but not just the capsule, but the spur also has been taken care of. So once you take care of the spur, you sort of create some space. You also sort of open the capsule and make some, you release the capsule so that the physiotherapy is way easier. So here the patient is 15th day post-surgery. As you can see, the same patient has 180 degrees of forward flexion. External rotation, placing the hands behind the head is satisfactory. This is, abduction plus external rotation. The patient has a good internal rotation. This was the most difficult movement to achieve for the patient. So internal rotation normally comes the last, but at 15 days, since we had released the posterior capsule, the internal rotation was easily achievable. So this is the video of the same patient taken 15-day post-surgery. So if you can see, he's easily able to raise his arm in all the directions. Now, the most important thing is that he should stay this way. So what we have advised him, he comes to us every week, at least once a week, and just show that he's performing the exercises. I don't want to leave him unattended. If he does not do the exercises after going home, or stops doing the exercises after 1 month, he tends to again get a stiff shoulder. So following up is very important in order to get the full range of movement. So in clinical practice, these are the two important frozen shoulders you will always present with. One is the primary and one is the secondary. So always differentiate between the primary and secondary if you want to give the, So again, I'll stress on the fact, for a secondary frozen shoulder, always palpate the shoulder. In palpation, if you feel that the long head of biceps is painful, it will point out to a bursitis inside the shoulder. You have to treat the bursitis before you advise the patient any sort of physiotherapy. So physiotherapy in terms of exercises, physiotherapy then should be given as an ultrasound or IFT to reduce the bursitis. Once the patient is completely relieved, then start aggressive exercises. And in a frozen shoulder, which is a manifestation of diabetic frozen shoulder, you can push, push, and push. So Physio Exercises in a patient with a primary capsulitis or a diabetic frozen shoulder will lead to improvement in the right direction. But in a patient with a long head or biceps which is tender will lead to capsulitis or will lead to deterioration, which is in the opposite direction. So you will be giving physiotherapy, but the patient will not be happy. He will be complaining. He will be, constantly saying that in spite of physiotherapy, my movement is decreasing. So always remember that it should be defined. So primary capsulitis, again, I'll repeat, push, push, and push. That is how you tell the patient that no matter how painful it is, no matter how uncomfortable it is, that is the best way he can get his movements back. So always ask the patient to keep doing it. And in secondary, treat the root cause and then push. Don't push before you treat the root cause. You will end up in a worse pain. So this is how I normally ask my patient to do an overhead stretching exercise. I always ask the patient to be supine, because in a standing exercise, the patient always tends to cheat. He always tends to move his back and feels that he's going higher, where the movement is actually not happening at the shoulder joint. The movement is happening at the back. So always ask the patient to rest the back, be supine, flex the knees, keep the elbow straight, keep the arm close to the ear, and then sort of pull the shoulder so that he gets active forward flexion. So this is a very important position for me for supine forward flexion. So this is the way I would look at a frozen shoulder. Now I'll take some questions because I'd like to have an interactive session. I think we have some time left. Hello? Yeah. So, I'd like to take some questions from the audience. I just try, stop sharing.
So everybody, you can put up your questions in the chat box and Apoorva sir will be happy to answer them. Please.
Or even if you want to keep the mic open, people will ask questions one by one. That's fine.
That's fine. Okay. Yeah. Yes, Mitisha, please.
Sir, if the patient has frozen shoulder due to diabetes, and after giving physio, the patient then starts complaining of pain in the deltoid and the biceps, but not in the insertion of the long head of biceps, then what can be done?
Okay. So again, as I said, every diabetic frozen shoulder is not a frozen shoulder because of diabetes. So I mean, every patient with a diabetes frozen shoulder, I'll rephrase it. Every patient with a diabetes does not have a diabetic frozen shoulder. Do you understand? I mean, what I'm trying to say is a diabetic frozen shoulder may have a painful biceps, and that may be the cause of the problem.
But then he did not have painful biceps earlier. I started physio, he had an increased range of motion, and after that he got slight pain in the biceps and the deltoid.
Correct. So, maybe your physiotherapy was heading in the right direction. He may have developed a secondary pathology along with it. Correct. So, whatever you had diagnosed him earlier as a diabetic frozen shoulder was the correct diagnosis. Hence, you were getting the right result. The patient was improving. The patient may have developed a long head of biceps tendonitis after a few sessions. It may have happened that way, and that is where then what your aim was to first treat the long head of biceps pathology and then continue your exercises.
Okay, and if the pain is not in the origin?
No, it's never in the origin. It's normally in the groove. So whenever you examine the patient, whenever you feel the biceps in the groove, the pain is always felt along the lower side of the biceps. So usually along the origin is very rarely felt. It's commonly felt along the groove, and then the patient complains of pain in the arm. So that is one of the important ways of diagnosing a biceps pathology. Pain up to the elbow. That is how you can feel it.
And is it normal for the patient to feel pain in the fingers as well, as radiating to the fingers as well?
So that is again a very mixed picture which they present with. So I have seen a lot of patients with a frozen shoulder say that they have pain in the fingers. So this is a very perfect question, because then we start thinking that it is a neural problem. We start thinking now that the neck is involved, because how will it be coming up to the fingers if it's a shoulder pathology? So the patients sometimes give a mixed picture, and that is where you can find out that if the patient has a painful shoulder movement, then it is just something which they're additionally feeling.
Yeah, thank you.
Okay. Yeah. Sir, why do patients with diabetes mellitus why does the diabetes mellitus cause frozen shoulder?
So as I said in the pathology, the diabetes is one of the causes of glycosylation of the capsule, and glycosylation leads to enhanced fibroblastic response. Enhanced fibroblastic response leads to stiffness. So the capsular thickening happens, and then it's sort of a lesser pliable capsule. The elasticity of the capsule reduces, and reduction in the elasticity leads to a stiff shoulder. So that is why a diabetes mellitus causes frozen shoulder.
Okay. Sir, we have next question. Can we suggest patients with chronic diabetes with any precautionary exercises in order to avoid the frozen shoulder?
Yes. So number one, in a diabetic frozen shoulder, always ask the patient to keep their diabetes under control. That is the first thing they do. So whenever a patient comes to you, diabetes should be primarily controlled. Along with that, they should be doing routine exercises in order to strengthen their scapular muscles, keep their deltoids strong, and keep their range of movements intact. They should not be doing heavy strengthening exercises, but they should be doing good stretching exercises. So a lot of patients come with a history of doing good yogasana. So I think they either do a lot of abduction, external rotation. They do a lot of forward flexion. They do circumduction. So they do these kind of movements. So any sort of movement which keeps the shoulder mobile is good for the diabetic patients.
Okay. Sir, what is the role of coracohumeral ligament in adhesive capsulitis?
So coracohumeral ligament is more of a operative a finding. So one of the things in an MRI, or actually when you operate, it's very difficult to differentiate a coracohumeral ligament in a stiff shoulder. So whenever you go in, it's a part of the capsular complex. So whenever we release the ligaments, whenever we release the superior glenohumeral, the middle glenohumeral, the inferior glenohumeral, the coracohumeral also is released. So it is a part of the capsular complex which has become thickened. So it is one of the important causes of stiff shoulder, and it is something which we go ahead and release when we do an arthroscopic release for the patient.
Okay. Sir, can primary frozen shoulder lead to secondary pathology?
No. So primary frozen shoulder can present with a concomitant secondary pathology, but cannot lead to a secondary pathology. So what are the worst that can happen in a primary frozen shoulder? They just get stiff. I mean, they just get stiff, they become painful, there is night pain, there is reduced range of movement, and that is a problem in itself. So secondary pathology along with a diabetic frozen shoulder must be having a different cause. Like, what happens is, I'll give you a simple example. Like for this particular question, there's a patient who has a very stiff shoulder, and suddenly they have a history of lifting something or have a fall. Then the capsule is so stiff, the patient has osteoporotic bone, that there is a fracture which happens. So that is a rare scenario, but it can happen.
Okay. Sir, does release of capsule compromise stability of the joint?
Yeah, so that's a very good question, and this has been discussed in a lot of orthopedic conferences as well, and some surprisingly it really doesn't. So we release the capsule 360 degrees. In a Bankard's repair, we try and repair the capsule. In the case of frozen shoulder, we release the capsule, but somehow capsular release with an intact labrum does not lead to instability. So always remember that whenever we release the capsule, we do not damage the labrum. We don't compromise the curve which has come, or the depth of the glenoid which has been there because of the labrum is kept intact. So maybe labrum plays an important role in giving them a stable shoulder. So that does not lead to any sort of instability.
Okay. Sir, apart from keeping your diabetes under control, are there any other methods, or are there any other ways to maintain the strength and mobility of your shoulder?
So, I mean, exercises are most important.
Okay.
Diabetes under control, along with the right set of exercises, will give you a painless shoulder. So always remember, whenever you see a patient with a past history of diabetes and they start complaining about the shoulder, catch them early.
Okay.
So, the thing which, again, I'll give you an example of what is happening around us right now. It's similar to a corona. Whenever there's a patient or one case, then you try and catch that case early so that he doesn't spread the thing around. So whenever a patient has a painful shoulder, you try and catch him soon. So that what happens is, you try and not get a frozen shoulder which has a forward flexion of 90 degrees. You try and start improving him right when he's having a good 160, 170 range of movement. You keep him there.
So early detection and maintenance.
Yes, early detection, immediate exercises after detection so that the pathology does not get worse. Don't wait for the shoulder to get completely stiff before you start the exercises.
Okay. Sir, if a rotator cuff tear, which causes secondary frozen shoulder, what will be the line of management in that case?
Yes, so secondary frozen shoulder, correct. So secondary frozen shoulder is very important